Welcome to the WPS GHA Contractor Advisory Committee meeting. Today is July 2nd, 2026, and the time is 6:00 p.m. Eastern Time. My name is Dr. Jody Sangstock, and I'm the co-chair for the state of Michigan. My specialty is podiatry, and I'll be moderating the meeting with my co-chair, Dr. Campos. The purpose of the CAC is to present the draft LCDs up for consideration and to take comments from the CAC. The public is welcome to attend in a listen-only capacity. Your attendance as a CAC member at this meeting implies that you consent to the public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the proposed or final draft LCDs discussed. If a CAC member does not consent, please disconnect now. The meeting is being recorded and transcribed. External recording, transcription, and the use of AI as a transcription tool or means of participation are not permitted. To aid in transcription, before you make any comments, please state your name, any conflicts of interest you may have, or state that there are none. Individuals wishing to comment may click on the raised hand icon. Press *3 if you are attending by phone. When Mr. Stanley calls on you, please make sure that your microphone is on at your end and that your speakers are silenced to prevent an echo. CAC members should follow any verbal comments in writing to Medicare policy comments at wpsic.com. At this time, I'm going to turn over the meeting to my co-chair, CMD, Dr. Campos, to talk about draft LCDs.
Thank you so much, Dr. Sangstock. Next, we are presenting draft LCD DL40385, anterior segment intraocular non-biodegradable drug-eluting system. This is a new multi-jurisdictional LCD. Dr. Juan Shaming is the responsible CMD, and Michelle McCary is the policy nurse analyst. The open comment period for this LCD is from May 21, 2026 until July 4th, 2026. Comments will not be addressed individually, but will be compiled and addressed in a response to comments document posted with the final LCD. Dr. Shaming, I'm turning over the floor to you.
Thank you. So I'm going to go over the proposed LCD indications and limitations. So the DL40385, anterior segment intraocular non-biodegradable drug-eluting system, the coverage indications and limitations are as follows. A single FDA-approved anterior segment intraocular non-biodegradable drug-eluting system is considered reasonable and necessary for the management of ocular hypertension or primary open-angle glaucoma per eye when all of the following criteria have been met. 1, history of failed medical management defined as try at least 2 ophthalmic topical drops given as sequential monotherapies or together simultaneously for the treatment of open-angle glaucoma or ocular hypertension, and the ophthalmic drops did not achieve the initial treatment goal of reduction of 20 to 30% from the patient's baseline intraocular pressure measurement, or adverse side effects from different ophthalmic drops severe enough to warrant discontinuation, or the patient is unable to physically place eye drops due to disability, such as severe tremors or loss of use of dominant hand, and there is no caretaker who is able to perform the administration of the drops. And the second, a history of failed selective laser trabeculoplasty, SLT, defined as the procedure did not result in significant reduction of intraocular pressure. The limitations of the LCD are as follows. Device implantation cannot be performed concomitantly with other eye surgeries or procedure except phacoemulsification, cataract surgery, If performed with cataract surgery, all criteria must be met and no other eye surgery can be performed at the same time. Implantation of the drug-eluting system is not permitted when contraindications as stated in the FDA label are present. The drug-eluting system cannot be re-administered within 2 years of insertion. Pre-implantation, Pre-implantation, the patient's central corneal endothelial cell density must be at or above the FDA recommended minimum central corneal endothelial cell density. Additional considerations, patients should be notified that the travoprost intracameral implant is magnetic resonance imaging conditional and may impact future MRIs and require additional precautions to scan safely. If readministration is performed because patient meets coverage criteria as noted on the LCD, the previous implant must be removed after the new implant is inserted. So now I will turn over the meeting to the co-chairs so they can obtain the comments from our CAC members.
Thank you, Dr.
Thank you.
Shaney. Any comments from our CAC members?
Yes, we have Dr. Appenzeller. You may unmute.
Hello, everybody. This is Matthew Appenzeller. I'm a CAC member from Nebraska, ophthalmology. Just making sure, do you hear me?
Yes, thank you.
Great, thank you. I have no financial conflicts to report. Let's see. I'm going to lower my hand so that I'm okay. I have a few considerations, things that I'm concerned about with this LCD that I would like to point out. At its basic, this is a very new technology, and the evidence behind its use and the clinical paradigms surrounding its use are rapidly evolving. And there is a feeling amongst there is a discussion amongst many of my glaucoma colleagues and my discussions with members of other professional societies that given our current limited clinical experience with this, that we feel that the proposed LCD is too restrictive at this time. There are a couple of points specifically. The step therapy requirements are, in our opinion, relatively problematic. For example, statement of saying that they have to fail 2 medications and one of the other 3 criteria as ORs becomes very difficult for one example, patients in nursing homes or patients that are not physically able to get drops in their eyes. How would they be able to fail 2 drops? Given that it says they have to fail 2 drops and have that issue. In addition, the first-line therapy for drops medication is prostaglandin analogs, and this drug-eluting stent is a prostaglandin analog and eluting stent. It doesn't quite make sense to require failure of a drug that's in the same class. And also given recent studies looking at non-inferiority between timolol and the drug-eluting stent, given these things together, it might make more sense to make this failure of 1 medication or 2, as opposed to has to be 2. Also, I have concern over the requirement that you have to also fail SLT, because there's no consideration that I could discern, and maybe I missed it, no consideration towards patients who are incapable of getting SLT. such as, and most of the time that's due to some physical disorder that they can't get into the slit lamp to have the SLT done, or, something along those lines. So I think it would make more sense that instead of saying and SLT failure, it should probably say or SLT failure. That currently is, and one other thing, the FDA, the approval for the FDA says 1 year, not 2 years, with regards to readministration. So I was wondering also if the LCD should be changed to reflect the FDA packaging. And then lastly, the central corneal thickness, or not central corneal thickness, the endothelial cell count, that requires specular microscopy, which is not widely available. There are lots of practices nationwide that don't have access to that. So it would probably be more reasonable to allow for other forms of corneal health assessment, such as corneal pachymetry or clinical judgment. That's all I have at the moment. So I am going to say thank you for listening.
Thank you, Dr. Appenzeller. We appreciate your expertise and your comments, and please follow up any of your verbal comments in writing to the Medicare policy comments at wpsic.com. Any other comments?
Yes, we have Dr. DiLorenzo followed by Dr. Poe. So Dr. DiLorenzo, you're up first.
Hi, can you hear me?
Yes, we can.
Yes.
Thank you.
Great. Thank you so much. I never know with these computers here. So I would like to echo everything that Dr. Appenzeller has said. And I think the big thing is that the concept is really, not whether this iDose TR should be covered, but how it should be covered. And so I'd like to say that, a policy like yours, and I know we all have the same intention, and I thank you, Dr. Schoenig and Dr. Campos, for reviewing this, that, we need to improve patient access and at the same time, preserve the judgment that we have as physicians. As Dr. Appenzeller said, we also should align with FDA labeling. So I think what we would like is that this is revisited and we revisit the coverage as additional long-term evidence becomes available. So that's what I'd like to say.
Thank you so much, Dr. DiLorenzo.
And Dr. Powell, you are next. All right, I am not hearing your mic. There you are.
Sorry, everybody. Thanks very much, Andrew Powell, CAC representative for Iowa in ophthalmology. No conflicts of interest. I am grateful for Dr. DiLorenzo and Dr. Appenzeller's advocacy. I largely agree. The point I just wanted to emphasize the clinical points for the SLT argument. There are also times when SLT waiting for it to work or taking the risk that it might entail is also not clinically appropriate. A small risk that the SLT potentially could make the pressure go up as well exists, and it does take sometimes a few months before it's actually clinically effective. There are circumstances sometimes where that's too long to wait or the risk is inappropriate. Thank you very much.
Thank you so much, Dr. Powell. We sincerely appreciate all our SME's expertise, and sure Dr. Schoenig will take your comments into consideration and again remind you to submit those in writing.
Thank you. Dr. Appenzeller again.
Yes, thank you. I just wanted to add that I think that in the end, what my ophthalmology colleagues and I are saying is that exactly that we feel that we're going to need to have an appropriate LCD. We completely support and would like to see it come, but I think we're basically saying we think it's a little premature at the moment. We would like some more time, and I think that what we would propose is that we keep this on a case-by-case review, because as we've just heard, there are many clinical circumstances where the individuality of the patient is paramount and will have a very hard time falling in line with this LCD. So as the use of this evolves and evidence-based medicine continues to grow around the use of this device, I think a well-structured LCD, it will be forthcoming. We just do not believe we're quite there yet, and we need to maintain individual review status for this device.
Thank you. And Dr. Shaning has his hand raised. Go ahead, Dr. Shaning.
Thank you. Thank you. I greatly appreciate the comments from our CAC members. As we always note, a proposed LCD is a work in progress. The intent of this meeting is exactly that, to get opinions from experts so we can consider them on the process of finalizing the LCD. All your comments will be taken into consideration. Please, you know that the comment period actually ends on July the 4th. So any additional comments that you want to submit in written form, please send it to Medicare Policy Comments at wpsic.com with any supporting literature, if any, and they will be addressed on the comment response document. And if and when the LCD is finalized, they will be taken into consideration. So thank you for your engagement and for your advocacy for our beneficiaries. It's greatly appreciated. I think that we are on the same page, that we want to provide reasonable and necessary services that improve the outcomes of our patients, that comply with our requirements of evidence-based medicine, 21st Century Cures Act. So your comments are greatly appreciated, and thank you.
Thank you, Dr. Shaning. Do we have any additional comments?
And just a reminder, if you're dialing in on the phone and want to make a comment, press *5 to raise your hand on the screen, and then I will select you, and *6 to unmute your phone once you've been selected. I see no further raised hands at this time.
Thank you, Rich. So this concludes the presentation and discussion of the draft LCD. I would like to thank the public for attending, and you may disconnect now. After a moment, we will continue the CAC members only portion of the meeting, where we will address contractor updates, projects, and provider engagement.